Assessing the patient's abdomen, I would ask the patient to lie back. I would inspect the abdomen for any swelling or evidence of ascites. Next, I would auscultate in all 4 zones, listening for bowel sounds. Bowel sounds are present. I would then listen for the aortic, or the aorta, listening for any bruits or thrills. Moving into the iliacs. And the renals. Next, I would palpate each of the areas for any tenderness or pain. Feel okay? Any pain or tenderness through here? I would also try to feel the borders of the liver and for any evidence of splenomegaly. Also noting the patient's skin appearance on the abdomen for any blemishes, lesions. Assessing the patient's respiratory system, I'll begin by inspecting the patient, noting the size and symmetry as well as the shape of the chest wall with expansion. I would note the rate and rhythm of breath sounds. The rate was measured at 14 breaths per second prior to the videoing of this segment. The rhythm is unlabored and there's no evidence of infiltrate upon auscultation. To begin, I would want a measurement of the patient's anterior and posterior chest wall in relation to the lateral chest wall. I want this to be a 2-to-1 measurement of the ADP versus the lateral measurement. I would then check the patient for scoliosis. I can do this by measuring the symmetry of the patient's shoulders, noting the symmetry of the spine, checking the symmetry of the scapula as well. Then I would want to check the patient for thoracic movement or thoracic upon expiration. I would do this by having the patient lean forward a little bit, place my hands midline on the spine, ask the patient to breathe in and breathe out, noting that my thumbs move away from each other on inspiration, towards each other on expiration. Following this, I would want to do measurement of the tactile fremitus by having the patient say 99, and feeling 99. The vibration
99.
In the different lung fields. And these vibrations are within expected limits. I would want to auscultate the breath sounds next with the diaphragm of the stethoscope. I would ask the patient to breathe in and breathe out. Breathe in, breathe out. Breathe in, breathe out. I would do this bilaterally. Breathe in, breathe out. Breathe in, breathe out. Breathe in, breathe out. Making sure to check the sides as well. Breathe in, breathe out. Breathe in, breathe out. While I have the stethoscope in place, I can check for vocal resonance. I would do this by asking the patient to say 3-3 or 33. And I'm checking all of the lung fields.
33, 33, 33, 33, 33, 33.
Okay. Next, I would want to check the whispered periloquy. I would do this by having the patient whisper 99, and I'm checking all lung fields as well.
99.
Upon this examination, you would usually hear a very faint whisper, if anything at all. Next, I would ask the patient to say a series of E's, as in E, 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 E. I'm checking all of the lung fields again.
E, E, E. 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 E, E, E.
Expected finding of this is that the patient will say they will actually have an E sound as opposed to an A sound. Finally, the last part of the respiratory assessment would be to assess for diaphragmatic excursion. The way to do that would be to palpate down, have the patient breathe in all the way and out, and then palpate down until the tone changes. And I would mark this with a pen. Next, I would have the patient breathe in all the way, and I would again percuss down until the tone changed. Assessing the patient's cardiac system, we'll begin this by palpating the chest wall for any lifts, heaves, or thrills. Which they're absent. I would auscultate the heart sounds using the bell and the diaphragm, starting with the aortic valve, midline over the chest, moving to the pulmonary valves, the tricuspid valve, and the mitral valve. I would again do this with the bell, starting midline with the aortic valve, moving to the pulmonary valve, the tricuspid, and the mitral valve. At this point, I would begin to assess the patient's vascular system, starting with the carotid arteries. I would first palpate one side and then the other. Then I would move to the brachial artery, the radial artery, the popliteal artery, posterior tibial artery, and the dorsalis pedis. I would also assess the patient's femoral artery and the brachial artery at the same time. Following this, I would auscultate the arteries, listening for any thrills or bruit, starting with the carotids, moving to the brachial, moving to the radial. I would assess the patient's femoral, popliteal, posterior tibial, and dorsalis pedis. Following this, I would ask the patient to lie on her left side. To assess the PMI. Feeling for ventricular